Surgeons Day. I welcome our chairman, Dr. Rajgopal for this program, today's program, and I request him to welcome all and proceed with the program.
Thank you, Dr. Sarvesh. We are sorry for the delay by a few minutes. As a chairman of Karnataka State Chapter of Surgeons of Surgeons of India, I welcome each one of you for this Surgeons Time. This is our KSC Surgeons Time. It's we started in March. Now this is our 4th month. Last Thursday of the every month. I welcome our executive committee members from the state as well as the national, surgeons, postgraduates, and of course our past chairman. We have a Dr. Immediate past chairman, Dr. Narayan Hepsur, and Dr. Ian Patil is also here. And most importantly, I would like to thank today's faculty, Dr. Krishna Chaitanya and Dr. Mamata, for sparing your time for us for educational activities. So without wasting much time, our chairman-elect, Dr. Naaz, Shaik, and Dr. Savitha, they will be moderating. So I request now Narayan Hepsur to say a few words.
Sir, thank you, sir. Thanks for welcoming us. And it is really nice that Surgeons Times is happening very regularly and without any hitches. And not only that, the activities of our KSCASI are really mind-boggling and everywhere. I think so. As Shivram sir said, it's going to create a world record if we collate all the data together. And all applaud goes to you, sir. You have really anchored the whole show very well. You have activated all the branches. 22 branches are totally active because of your charisma, whatever you are carrying, sir. It is really great. Wish you all the best, sir. And I know next year Naaz madam will do much better. She's a real shining star all the time, and she'll also do well. Wish you all the best, sir. And wish you have a great time, sir. Thank you.
Thank you. Dr. Patil, idera ನೀವು? Dr. B.N. Patil? Idara? Okay.
Unmute ಮಾಡಿ.
Idara?
ಇದ್ದಾರೆ.
ಮಾತಾಡ್ರಿ, B.N. unmute ಮಾಡ್ರಿ.
Unmute ಮಾಡಿ ಎರಡು ಮಾತು ಹೇಳಿ.
B.N. unmute ಮಾಡಿಲ್ಲ ನೀವು.
Yes.
Yeah.
ಹೇಳಿ ಪಾಟೀಲ್ ರೇ.
Hello.
Yes.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. Good evening, everyone. I request Dr. Naaz madam to continue this CME program in the coming year with much better than what Dr. Rajgopal is going to do right now. He has activated all the branches throughout Karnataka. He used to contact each and everyone personally and make them to participate in the CME program. At the same time, we are conducting on behalf of KSCSI Vijayanagar branch. This Saturday, we are going to celebrate a Surgeons Day, and we will honor senior surgeons, Dr. Chinwalar and Dr. Prakash Reddy. Every branch is totally activated, and each and every branch is conducting a Surgeons Day celebration as well as regular CMEs. I once again wish all the best to Dr. Rajgopal as well as Dr. Naaz madam in the coming year. Let them do better than what we have done before. Okay. At the same time, I thank Dr. Narayan Hepsur, Dr. Shivram sir, and Dr. Rajgopal and Dr. Naaz madam for who gave us an opportunity to serve the Karnataka State Chapter as a chairman. And I thank each and everyone, all the members of KSCSI for giving us an opportunity to serve. And they are going to serve better than what we have done before. All the best for the new team as well as the present team, Dr. Rajgopal. Okay, thank you.
Thank you. Madam, please take over.
Yes. Thank you. Good evening, everyone. Thank you, Dr. Narayan Hepsur and Dr. B.N. Patil for those kind words. At the outset, I would like to thank each of the participants for taking time to log into this program. And I also thank Dr. Rajgopal Shenoy, sir, our chairman, for giving us this opportunity, along with Dr. Savitha, a vibrant and enthusiastic EC member of the state chapter, to moderate this session. And today we have chosen a very important topic on arterial disorders and the management. This is one topic which we commonly miss out as general surgeons because we are more concentrating on abdominal wall repair, thyroid, breast, GI surgery, and so on. And so we thought we'll update our knowledge on the vascular disorders. We had the venous disorders last month. So I thought we'll update. And I always look upon Dr. Mamata as one of a speaker. Anytime I call her, and she's always there for me. Thank you, Dr. Mamata and Dr. Krishna Chaitanya, for accepting our invitation. And we just remembered our good old days of vascular surgery was for Berger's disease. It was a lumbar sympathectomy and omental graft, and all these have become obsolete now. And vascular surgery has been taken up by the vascular surgeons, and they've added life, mobility to the dying life of so many people with vascular disorders. And I thank Dr. Mamata once again and Dr. Krishna Chaitanya for heartily accepting this invitation. And I would begin this, ask Dr. Mamata to begin her talk. And for a brief invitation, for a brief um, introduction of Dr. Mamata, I would say she's working at Jivas Bhagwan Mahaveer Jain Hospital, Bangalore, and she has she's an alumni of MRMC Gulbarga, and she's privileged to be the first in many of the many fields across India, and she's the first lady vascular surgeon of qualified in India, and she has worked in multiple hospitals across Karnataka, and she has started the endovascular surgery at KLE, and she has initiated the Department of Vascular and Endovascular Surgery at Narayana Hrudayalaya, Hosur Road, Bangalore. She has also published several papers, and one of her paper, that is subclavian arterial stent migration from technical error and effective bailout, is published in Indian Journal of Vascular and Endovascular Surgery, which has also been awarded in the international conference held at Bangalore. And she has many more what we call it as achievements. And if this whole hour will not be enough for that, I think Mamata should proceed. Over to you, Dr. Mamata.
Thank you so much, Dr. Naaz, for giving me such a big opportunity to present here today and a lovely presentation of my CV. Thank you so much. And thank you, Dr. Shenoy, sir. It was pleasure coming across and having a time to present here today and giving me this opportunity to present here. Yeah, so screen sharing. No, that is not. I think so, Martin, if you can share my, again, it is
bottom of the screen.
At the bottom, ma'am, you can see a green button called share. You can just click that.
Yeah, shared, but I'm not
You
seeing.
can select that PPT and present it as share, ma'am, or you can just press share whole screen, entire screen, ma'am.
Yeah, I think so. It's visible now.
No, ma'am.
No, not yet.
Desktop ಅಲ್ಲಿ ಇಟ್ಟು first open ಮಾಡಿ first slide, then share. It becomes easy, I think. Just check.
No, not able to. Can you get that? Share. Show presenter. Share and Go to Zoom.
Ma'am, have you pressed share button, ma'am?
Yeah.
In that, you can see your PPTs in application windows. Now it is loading, ma'am.
Okay. That's advanced.
You can just start from the first, ma'am.
Yeah.
Yes.
Yeah, I think so. It's clear now.
Yes, madam. Please go ahead.
Yeah. So as Dr. Naaz said, this is one of the most neglected vascular surgery subject. I think so, where more and more of awareness is required as per the present scenario, where we are seeing so many of the vascular patients coming up with so much of morbid conditions. So to start with, the vascular surgery was initially initiated in the early 20th century, and it started with arterial ligations, and totally 101 surgeries only, to be very specific, in 30 years was conducted, and it was only to maintain the functional restoration. It was Matas and carried over by the Carol. The aneurysm was first treated, and again it was again the ligation itself. In early 30s, the iotography was performed when the iodine based Binz et al. Invented the dye was conducted and first iotogram was performed. So in the early 1940s, the techniques and interventions zoomed up with the entry of safe anticoagulants, which were routinely implemented in our vascular practice. And in the year 1953, Scheldinger's technique came in. With the evolution of radiologist, mainly the Charles Daughter in the 1960s, he coined the first endovascular therapy from a remote place, where he started giving the concept of catheter-based or catheter-directed angiography. Then came the balloons were introduced. The Grunzik was the person for the introduction of these, treating remote lesions from a easily accessible femoral access. And the development of metallic stent was first invented by Mr. Palmer, who was the first to introduce these stents. So now, why these claudicants rarely need the intervention? What is the concept of the vascular surgeons? How we go about it? The claudicants rarely progress to a limb loss that is less than maybe up to 1% maximum. And from a progression of peripheral arterial disease in an asymptomatic patient, going to a mild claudication to disabling claudication to critical takes months to years. But this can be hastened or further progressed to the fastest level to have a critical limb threatening ischemia, could be because of the thrombotic occlusion, or in our Indian scenario, it is mainly because of the bare walking foot and the concept of going to temples barefoot, puja punaskara, and all those things add up, and poor footwear also is one of the cause for it. So what is that we are doing separate from that as a vascular surgeon? So first we presume and come to a conclusion like what the state of the diagnosis is. First we confirm the diagnosis, the grade of functional severity, then we assess the disability and the natural course and opt for the best medical management. Or we categorize along with the low risk or high success of the interventional options. Then comes our, when the intervention is needed, we confirm the diagnosis and then analyze the extent of the degree of involvement in the form of angiography. Most importantly, nowadays what we do is tentatively we prepare for intervention at the time of angiography to avoid the risk, the time and the effort of the surgeon itself. So as soon as the patient comes, first thing what we do is whether the patient is ischemic or not, first our fingers goes on to the foot pedal pulses. We are so much addicted to this feeling of pedal pulses is as soon as the see a person's legs, our hand goes and stands on the foot. So next comes is the handheld Doppler, that is our stethoscope. Once we don't feel the pulse, we straightway go to the handheld Doppler. The modified ones, we even get the graphical presentations of this. And next, simpler, non-invasive is the arterial Doppler. So arterial Doppler, which comes. And pulse volume recording and arterial Doppler are the two important indications that we categorize only for the claudicants. The angiographies, the CT, whether it could be MR or conventional angiography, is specifically noted for a intervention part. But for a claudicant, let me stress on this, we never do it. It is again, the angiography is carried out only to plan for the surgical intervention and not for the diagnosis. Let me stress on this point. And ultimately, the conventional angiography, what we routinely do, that is the cath lab, what we carry out is ultimate gold standard for the vascular evaluation. And the complications are less than 5%, and the mortality is about 0.25%. So what is that surgery we decide upon? How we take the decision of making whether the patient undergoes a surgery or an endovascular procedure? For an open surgery, it is always young patient, definitely yes. Low comorbid conditions, yes. Long occlusions of the artery, yes. Whether it is a femoral artery or the iliac, so long occlusions are always a first priority as a open surgery. So we consider endovascular only when in a very high comorbid condition patient or a small lesion, stenotic or multi-level, or we combine both the surgical and the endovascular procedures. So now the difference comes, what is the difference between the open surgery and endovascular? Why this endovascular is being evolving so fast? You can see the trolley with instruments in an open surgery, whereas that in a table of endovascular, it is instrument maximum. What we use is one artery, mosquito artery, along with one small knife. Other than that, everything is guide wires, pipe, catheters, mops. So this is the simple procedure of Scheldinger's. That is the sheath, introducer sheath. Along with that, this is the guide wire and two syringes, one for the heparinized saline and other will be for the dye. So now again, this is the difference between open and endovascular. You can see the open surgery, we have to open up the artery, the entry artery and the target artery, and the vein being harvested all the way from the groin up to the leg level, depending on the length of the vein which is required. Whereas you can see in the endovascular procedure, it is just a needle puncture through which all the procedures are being done. So always the puncture is done with the ultrasound guided. So you can imagine the blood loss, how much we will be having in a endovascular procedure. And you can see the mops and clothes hanged over and the amount of blood that is being shed out in an open procedure. So let me come to some of the interesting cases which recently have been operated and the morbidity of the patients when they come in a later stages in a delayed presentations. This young chap, 65 years old gentleman who came to me in this condition of a dorsum foot with tendons exposed with a necrotic tissue. And he had already undergone an anterior tibial angioplasty somewhere else, which was mentioned as could not be carried out because of the wires could not be carried on. So once the patient comes, as soon as we look is for the functionality, as I already mentioned, and the salvageability of the foot. How bad is the foot? So this is when we carry on with this. So this patient underwent a subtraction angiography directly, because already we know there is no proximal lesion. So directly we enter into the femoral artery, access through that. And he underwent posterior tibial and common plantar angioplasty along with transmetatarsal amputation because of the extending necrosis. So this is what you can see the stenotic lesions here, and the common plantar hardly is visualized here, where it is ending, and this is the stenotic lesion where my wire is trying to pass over here. I think so it is clearly visible. And this is how the posterior tibial artery angioplasty is being carried out with long balloons, depending on the size of the artery. And you can see post-angioplasty, the whole of the artery is being opened up, and you can see the common plantar being filling up so nicely and forming the plantar to cover the plantar aspect of the foot. So you can see the revascularization, the foot here, and the peroneal also being opened up along with the common plantar artery. So this will be the last foot shot which we normally consider, and that is the completion angio, what we call it as. So this is the present status of this patient, who is doing excellently fine. He is just waiting for the skin grafting, and you can we always assess the patient with the revascularization by the PVR accordingly with the waveforms and the improvement in the ABI. Whenever the ABI is being recordable in heavily calcified, it is very rarely. So again, it is the waveforms which we depend upon. So this is another similar patient who came with a single toe gangrene. You can see other leg, the right leg, who had already undergone transmetatarsal amputation in 2017. But you can see the angioplasty result here too. Even after 7 years, his foot is quite good. Unfortunately, he came neglected for his left toe gangrene. So he came to us when we had to take for our angiogram, where we noticed popliteal artery, tibio-peroneal trunk, and the posterior tibial artery being stenosed. The whole of the SFA is quite good. And here you can see the TPT being occluded. I think so this is quite clear. This is the completely TPT occlusion. And this is the posterior tibial runoff. So this is how we carry on with the angioplasty. The guide wire is passed and launched into one of the branches, and get the balloon down and try to balloon it and try to open it up. Here you can see the post-angioplasty. Nicely opened up tibio-peroneal, and this is a zoomed up, and you can see the posterior tibial up to posterior tibial, where you can see the common plantar absolutely crossing over the foot. Well, again assessed by the ABI, excellent ABI improvement 0.58 to 1.03. This is the patient. Unfortunately, this patient landed up with multiple infection, multiple abscess formation, and every culture report kept showing as no growth. So we had to arbitrarily put him on antibiotics, thorough wash, put him on regular WAC dressings. And presently this is, and every tendon kept tracking the pus. So this was the scenario of this, and most of these long-standing diabetic patients, they land up with a small vessel disease, which is very, very notorious and very neatly and delicately to be handled up, where only debridement is the only answer for such patients. And this is another case, something similar. This patient presented with in 2022. Oh, where is my cursor? Yeah, this patient presented to us with this present situation with very bad cellulitis and multiple bleps all over the leg. So, and unfortunately, this patient again was undertaken for a angioplasty in 2022. This time again, the patient neglected for the same. So what we normally do is assess, as I told, the functionality and the heel involvement, whether it is there or not. If there is a heel involvement, then whatever the procedure of revascularization is done, absolutely it is not worth going ahead. So we always assess for the heel and then think of going for a revascularization. So this patient underwent, you can see the SFA quite lesioned here, and the anterior tibial artery was significantly diseased, and a single vessel runoff, the peroneal, and both were absolutely not there. So this is the procedure of angioplasty at the SFA. And always we have that once angioplasty is done, stenting is not a must, not necessary. Definitely, depending on the situation, if there is no dissection, definitely we will opt for a angioplasty alone without any stent. Unfortunately, the anterior tibial artery could not be opened up by our regular femoral puncture. So retrogradely, we had to come from the anterior tibial artery and cross the lesion of the anterior tibial artery. And ultimately, the angioplasty was done and it was successfully done. And here you can see the difference of, this is the pre-op, this is angioplasty part, and this is the post-op flow. Here is the anterior tibial stenotic occlusive disease, angioplasty done, and this is how nicely it is opened up. And again, the foot arch, what I always kept telling is this. This patient also significantly improved his ABI from 0.48 to 0.74. This is again a multimodality approach patient where the patient was with vasculitis, diagnosed as rheumatoid arthritis some 2 years back. He was on steroids and all with ANA positive. He was a smoker and a alcohol intake, but no diabetes or. This patient has undergone popliteal to anterior in view of a long segment anterior tibial, had to go think of a vascularization in a open surgery. So this patient underwent popliteal to anterior tibial angioplasty. So post-op recovery was quite excellent. So this is for the upper limb, what we routinely do. This is a subclavian artery, which is clearly visible here. Unfortunately, what happened was the stent, what we had put at the subclavian level, it just migrated and came. As soon as we put it, we could see it in the chest. And in no minute, it went into the abdominal aorta and then lodged into the common iliac artery. You can see the stent. So with the, you can see the stent here. The balloon was inflated within the stent and brought it back to its place and lodged into the subclavian artery. And now you can see the stent in place and a beautiful stent opened up and the flow across the stent. Here, just to demonstrate the stent, where it migrated and how it went, and the balloon being taken off along with the stent. This is again a case of mesenteric ischemia. The SMA is being cannulated from the femoral artery. Branch went in the catheter wire being launched into the branch, one of the branch. Catheter passed, and once it is ready, this is the stent which we placed into the superior mesenteric artery. You can see the stent opening up. And the beautiful flow you can just visualize here. Something similar for the common iliac also. There is a stent occlusion. There was a stent placed earlier which got occluded, so it had to be opened up, the clot removed, and in situ the stent angioplasty was done. This was the angioplasty within the stent, where the balloon have been crossed. To prevent opposite side kink, we go for a kissing balloons balloon plasty for such iliac bifurcations. And here you can see the flow into the iliac arteries. So with this, I would like to tell one thing. As soon as the patient comes to us in a claudication or a small wound of a small gangrene like this, or a small ulcer like this, the definitive treatment is definitely going to last long, and the morbidity associated complication of mortality also are definitely higher. Definitely would like to see the patients in earlier these type of presentations, not absolutely in this type of presentations. So what is that we are thinking now? Is arterial intervention a game changer? Definitely, I feel it is yes. How? It's arterial revascularization in the critical limb ischemia. The limb salvage is definitely 90%, and clinically diagnosed early and treated by a qualified vascular surgeon, definitely the limb salvage rate is quite high. And with the newer advanced technology, whether it may be a hardware or a software in a minimally invasive techniques, the results are quite satisfactory. And the risk of definitive morbidity and mortality are reduced until and unless the patient present to us in a earlier stages rather than coming at a late stage. So in delayed presentation, the major tissue loss is there. Definitely the outcome is poorer, and the morbidity and the patient to come to a pre-morbid state definitely takes a very, very long time. So I would suggest as early as possible, if the patient is treated early, outcome would be the better option for the patient as well, to the doctor as well. Oh, I think so. That's the end of the. Hello.
Yes, yes.
Yeah.
Dr. Mamata. Thank you for that excellent presentation, and thank you for sharing these wonderful videos with us. And it is indeed heartening to see all these patients with coming with a sloughed wound, and then the wound changes to a pink color. And all the credit, I must say, goes first to the person called Werner Frostman, who first introduced, showed us that we could enter the arteries and do something. That is, the whole of interventional surgery started with him. And, that is, you agree with me?
Exactly.
Yes,
Exactly.
yes.
I think so. The game changing starts there.
Yeah, starts there. Exactly. And I think there are no questions in the chat box. So anybody wants to give some comments or some, Dr. Sunil, Shenoy sir, anybody wants to?
It's a good talk. Probably questions, if it is there, we can take later. At the
Later,
same time,
okay.
just want to add only one point that, as rightly told, the aim is to preserve the limb, and once there is an amputation, they also have got a rather accelerated rate of death also. That's another important issue because of the mobility itself is lost. Dr. Sunil has raised his hand.
Yes, sir. So what we should also note is that it's very important to give appropriate medical management to these patients. I think, of course, the topic was about surgical or intervention, but what happens is usually in general surgery or any other practice, when once the patient has an amputation, we forget that he needs to continue. Despite of that, he needs to continue on antiplatelets and statins and other things. So medical management should not be stopped at any cost. Once he is a vascular path, he needs to continue because he can have diseases in the other leg or in other systems of the body. So medical management is very important. That is one thing we need to note, because sometimes if a patient has an amputation, we feel that the disease is over. I don't know how many of you agree, but it is in practice it happens. Second thing is, I think we'll have to speak about medical management is during any general surgical procedures, if the patients are on antiplatelets and other drugs, how to manage them and other things. I think we can discuss this at the end of the presentations.
Yeah, definitely the lifestyle modification adds a lot to this. Add to Sunil's words, I think so the lifestyle modification comes first, especially to abandon the further progress of the vascular disease.
Thank you, Dr. Mamata.
Thank you.
Dr. Savitha, could you please take over?
Thank you, ma'am.
Yeah.
It was a wonderful and enlightening talk, madam. The questions are there in the chat box. We'll take it later. So before I introduce the second speaker of the day, I would like to thank our chairman, Dr. Rajgopal Shenoy sir, and chairman-elect Dr. Naaz madam for giving me this opportunity to moderate this session of today. Our second speaker for today is Dr. Krishna Chaitanya. He is currently working as a lead consultant vascular and endovascular surgeon in the Department of Vascular and Endovascular Surgery at Aster CMI Hospital and Aster RV Hospitals in Bangalore. Sir has finished his MBBS in MS Ramaiah Medical College in the year 2005, and he has bagged second rank during his MS General Surgery, which he has done in Adi Chunchandgiri Medical College. Sir has done his MCH Vascular Surgery in MS Ramaiah Medical College 2015. He is also served as a consultant vascular surgeon in Yashoda Hospital, Hyderabad and Columbia Asia, Bangalore. Sir is experienced in performing open and endovascular peripheral vascular procedures with a strong focus on aortic interventions. He is extremely passionate about training and mentoring. Welcome you, sir, to deliver your talk on aortic and peripheral arterial aneurysms, overview of open and endovascular management. I think it's one of your favorite area of expertise, sir. Welcome, sir.
Thank you, ma'am. Thank you for your kind words. Thank you, everyone. It's an honor to give a talk here. Without much of wasting time, I'll share my slides. Please let me know if it is visible.
Dr. Krishna, can you, if possible, enhance the audio, please? Maybe at your level or, yeah, because, yeah.
Can you hear me now, sir?
Better. Yes.
Thank you, sir. Is my slides okay?
Yes, sir.
Yes, sir. It's visible.
Thank you, ma'am. So the topic I'll be talking is about arterial aneurysms, aortic and peripheral. Now, just a minute.
So I think so it is due to animation. So I can just press once again.
I'm doing that. Unable to share. One participant share at a time.
No, so your screen is currently being shared.
Are you able to see it?
It is just blank, sir. Else I can just cancel it and you can share it once again, sir.
1 second. I'm unable to share it. I just 1 second. I'll stop the share. Is it okay?
It's loading, sir.
Seen, sir, now visible.
Visible?
Yes, sir.
I don't. Okay.
Yeah.
So any abnormal, permanent localized dilatation of the artery more than 50% of its normal diameter is called an aneurysm. For example, if the adjacent artery's diameter is about 10 millimeters, a 15 millimeter dilatation of the artery qualifies to be called an aneurysm. In the arterial aneurysms, according to the NIH data, the commonest site happens to be aortic aneurysms, particularly that of the abdominal aorta. This is followed by berry aneurysms, particularly of the arteries forming the circle of Willis, the iliac arteries, which also form a contiguous part of the abdominal aorta, the popliteal arteries. The popliteal arteries go through a lot of shear forces throughout the life of an individual, and coupled with atherosclerosis, are one of the common sites of arterial aneurysms. The femoral arteries, which are one of the frequent arteries which are accessed for percutaneous interventions, we see a lot of pseudoaneurysms of the femoral arteries. Then comes the visceral artery aneurysms, particularly that of splenic artery and gastroduodenal arteries. What causes an aneurysm? If we look at the etiological factor, we can broadly divide them into 4 or 5 reasons. The developmental and degenerative factors, while several young individuals with connective tissue disorders like Marfan syndrome, Ehlers-Danlos syndrome can present with aortic aneurysms at a very early age. Conditions like cystic medial necrosis, atherosclerosis, a very important factor where the vessel wall is weakened due to atherosclerotic process. Cigarette smoking is a single major independent risk factor for development of aneurysms. Certain aneurysms also run as familial disorders. Mycotic aneurysms, which are not fungal aneurysms but bacterial aneurysms, can happen due to bacterial infections, the commonest being Staphylococcus aureus and also Salmonella. Chronic infective conditions like tuberculosis and syphilis can also cause mycotic aneurysms. Vasculitis is another important factor in development of arterial aneurysms in young and middle-aged individuals. Takayasu arteritis is one of important conditions where there are aortic and carotid aneurysms. Certain conditions like ankylosing spondylitis, rheumatoid arthritis, SLE can also predispose an individual to development of aneurysms. Inflammatory conditions like Behçet's disease is an important condition where we see aortic aneurysm as initial presenting symptom. Trauma often leads to development of pseudoaneurysms. Now, what is the pathology behind these aortic aneurysms? As in many other conditions, vascular inflammation is the initial factor which leads to development of an aortic aneurysms. Due to this inflammation, there is infiltration with immune cells, which in turn produce cytokines. Now, these cytokines lead to degradation of extracellular matrix. There is increased activity of matrix metalloproteinases. This leads to degradation of extracellular matrix proteins, mainly the collagen and the elastin. Subsequently, there is apoptosis of smooth muscle cells in the tunica media of the artery. Now, as we know, there are 3 layers of the artery: tunica intima, media, and adventitia. What happens in an aneurysm is adverse extracellular matrix remodeling, which leads to weakening of the arterial wall, which cannot withstand the arterial pressure and subsequently enlarges and dilates to form an aneurysm. What are the types of aneurysms? When we look at the aneurysms, there can be true aneurysms or false aneurysms. True aneurysms have all the layers of the artery, while false aneurysms do not have all the layers of the artery within the aneurysm wall. In true aneurysm, when there is uniform dilatation of the artery, we call it as a fusiform aneurysm, while only one wall outpoaches like a saccular outpoaching, we call it as a saccular aneurysm. In false aneurysms, there can be 2 types. One is dissection aneurysms. Whenever a patient has a dissection of the artery, like in aortic dissections, there is a tear in the intima. Because of this tear in the intima, the blood starts entering a subintimal plane. That is, it enters outside the intima into the subintimal, that is, into the media. And this damaged layer does not have the strength to withstand the arterial pressure, and it starts distending, forming a dissection aneurysm. While in a completely false aneurysm, there is usually an arterial injury which leads to extravasation of the blood outside the arterial wall. Now, this blood is contained by the compression of the surrounding tissue and the thrombus, which is subsequently formed. Now, when we look at the problems with the aneurysm, most of the cavitatory aneurysms tend to rupture, like thoracic aortic aneurysm, abdominal aortic aneurysm, or even intracranial aneurysms. They often present with rupture as a complication. While those in the extremity, like a femoral artery, popliteal artery aneurysm, or a subclavian artery aneurysm, usually present with thrombosis or embolism, distal embolism, leading to limb ischemias. Aneurysms can also have complications due to compression on surrounding structures. For example, a popliteal or a femoral artery aneurysm can compress the deep veins of the limb, leading to deep venous thrombosis. Nerve compression can lead to pain or even paresis. Due to expanding aneurysm, the skin overlaying the aneurysm might get necrosed. Abdominal aortic aneurysm can erode the vertebrae, which we call as scalloping of the vertebrae, sometimes even leading to fracture of the spine. Thoracic aortic aneurysms can erode into the pulmonary trunks, leading to massive hemoptysis or even lead to aortoesophageal fistulae. Now, behind this aneurysm pathology lies several laws of physics because it is a tubular structure with flow under pressure. The most important law is the Laplace law, where the inner tension or the endotension is directly proportional to the diameter of the tubular structure. That means the bigger the aneurysm grows, the bigger is the endotension and the more the chances of rupture. Also, because the tubular flow is lost, there is turbulent flow. Because of the turbulent flow, there is decreased velocity in the sac, leading to thrombus formation and subsequently decreased perfusion pressures downstream. Now, with this idea, let us look into the management of these aneurysms. Now, when we come to management, the aim is basically to prevent complications. Now, how do we prevent complications? Aneurysm is an abnormal event. Because of this, we have to exclude the aneurysm from the circulation. And how do we do it? Like, this is my rough pictorial diagram. I'm not a great artist by any means. So here, in this pictorial diagram, the first we can see exclusion by a bypass graft. We can ligate the aneurysm above and below and exclude it from the circulation by creating a bypass graft using an autologous vein or an artificial conduit. We can even replace the segment by excising that segment and interposing with an autologous vein or an artificial conduit like a Dacron or PTFE material. In endovascular era, we have started to internally exclude this aneurysm by means of a specialized stent graft called a covered stent or a stent which is covered by a layer of fabric called stent graft. Here, the blood tends to flow into the stent from above and comes out from below without any extravasation of the blood outside the stent graft, preventing further expansion of the sac or even rupture. It is very important to note that aneurysms are repaired from normal artery to normal artery, and we need at least 10 mm of the normal artery above and below the aneurysm, 10 mm of branch-free normal artery to perform a repair. This is a pictorial diagram of a popliteal aneurysm where we can see various types of repairs being performed for the same. We'll look into that a little later. Now, with this idea, let us quickly look into some clinical aspects of it. Now, this is a CT angiogram of a patient with popliteal artery aneurysm on the right lower limb. It's a true aneurysm where we can see the sac is open and a bypass is performed by a autologous vein. This is another case of popliteal artery aneurysm where a covered stent has been inserted into the aneurysm. Now, we do not see any sac, thereby preventing the thrombosis or embolism downstream. This is another case of popliteal artery aneurysm with significant tortuosity of the artery. Another covered stent has been placed. This is an important case where a patient initially presents with lower limb ischemia. After removal of the thrombus, it is very important to do a check angiogram. On check angiogram, we identify there is an aneurysm of the popliteal artery, which is in fact the reason for his lower limb ischemia, and subsequently a covered stent has been placed. Now, this is a distal femoral artery aneurysm for which an interposition bypass graft with a great stiffness vein has been performed. This is true aneurysm of common femoral artery right at the bifurcation. for which the bifurcation is recreated by a Dacron graft. We can see the bifurcation of superficial femoral artery and profunda femoris artery. This is true aneurysm of radial artery, which was thought to be a ganglion. Subsequently, they even noticed pulsations in that. So when we did an Allen's test, it was positive. When we did a Doppler, the ulnar artery was occluded. Otherwise, these aneurysms can even be ligated. But because the ulnar artery was occluded and Allen's test was positive, we created a small interposition bypass graft using the cephalic vein from the arm. Another very important case is subclavian artery aneurysms, which can often occur due to cervical ribs. Due to chronic compression and trauma to the artery, subclavian arteries can get aneurysmal, which can be one of the important factors in patients presenting with upper limb ischemias. This is a splenic artery aneurysm for which a covered stent has been placed, and subsequently we can see good flow through the covered stent. Splenic artery aneurysms can also be treated by coiling, or if the aneurysm is close to the hilum, a splenectomy can also be performed along with the aneurysm. Now, this is a very interesting video of a pseudoaneurysm. The femoral artery is here, and we can see the blood slowly in a turbulent manner or with lack of laminar flow circulating in the sac, which does not have any walls. It is in fact the thrombus and the compressed surrounding tissue which are forming the sac of a pseudoaneurysm. This is a lady who underwent a coronary angiogram, found to be normal, but subsequently kept complaining of groin pain. After a certain while, when the swelling in the groin started increasing, we realized that there was a pseudoaneurysm. We have actually occluded the artery by loops here, and that is the hole from which she was bleeding. Once we loosen that loop, to show you where the puncture hole for the intervention was there, that is the point. Once we loosen that loop, we can see, once the arterial flow is restored, we can see the blood starts jetting out of that arterial hole. So that was closed by a simple stitch. Sometimes when patients undergo coronary interventions and they undergo even stenting, they're already loaded with a lot of antiplatelets, which makes surgical options extremely difficult. Like in this case, the puncture was in the profunda femoris artery, and patient had a pseudoaneurysm of the profunda femoris artery, which was treated by a covered stenting. Sometimes even in our practice, when patient during percutaneous intervention after angioplasty due to trauma to the vessel, pseudoaneurysms like this can develop, which can also be treated by placement of a covered stent across that pseudoaneurysm, thereby sealing of the pseudoaneurysm. Aortic aneurysms. This is one of my favorite topics because given an infinite lifespan, most of our aortas will become aneurysmal. Now, why should we worry about aortic aneurysms? Now, that is the life expectancy of our country from 1800 to 2020. As we see from 1920 onwards, with the development of modern healthcare, our life expectancy has improved to beyond 70 years as on today. So the more older population, the more years we live, we see more of degenerative problems, and aortic aneurysm is one of such conditions. We are always proud, and we often see many politicians and economists telling that India is a young country, so our economy is sound and strong. But that is as far as it is today. If we look at the projection of our country in the next 10 years, we will see a decline in the younger population. We will have more of senior citizens in our country. So these are problems with aging population. Now, it's not a new disease. Great Albert Einstein also died of aortic aneurysm. In fact, his treatment was, they had just wound up his aneurysm with a cellophane tape, which did not last too long. Several famous celebrities also had aortic aneurysms. There is a big problem with aortic aneurysms in India. That is, most aortic aneurysms are asymptomatic. Patients do not accept that they have something that grave inside their body until they present with rupture. Incidentally, some of the fortunate individuals have it detected on CT or ultrasound done for unrelated conditions, kidney stone or a vague pain abdomen, only then these aortic aneurysms are detected. Globally, it is seen that about 8% of men above 65 years suffer from aortic aneurysms. There is no statistics from India about the incidence of aortic aneurysm because there are no screening programs in India. Apathy towards well-being of elderly. Even though the problem with treatment of aortic aneurysms is most of these aneurysms develop in people aged 60 years or 65 years or above that. And when it comes to expensive treatments for conditions like this, most of them shy away, telling that already stage agide sir, ee vayasal istondu ದುಡ್ಡು ಖರ್ಚು ಮಾಡಬೇಕಾ. These are honest questions which are posed to us. Now, that being said, what is the size at which, suppose we see an aortic aneurysm, what is the size at which these aneurysms have to be treated? Now, the guidelines say that if there's a fusiform aortic aneurysm above 5.5 centimeters, this is for infrarenal abdominal aortic aneurysm. Fusiform aortic aneurysm above 5.5 centimeters should require a treatment, whereas in women who tend to have smaller arteries than men, the size is 5 to 5.4 centimeters. Any saccular aneurysm at the point of identification should be treated because it is the single wall which is enlarged and there are more risks of rupture with saccular aneurysm. Irrespective of the size, all saccular aneurysms have to be treated. However, if a patient has aortic aneurysm less than 4 centimeters, but it is expanding at more than 1 centimeter a year, or if the patient has symptomatic aortic aneurysm, like there is scalloping of vertebrae, back pain, abdominal pain when all other factors are ruled out, or some other complications like to compression on the surrounding structures, or any of these complications, these aneurysms warrant earlier repair. Now, how did they arrive at 5.5 centimeters? That's an interesting story because this is the data published in Journal of Vascular Surgery, where if we can see the last couple of rows, the mean diameter of aorta in the infrarenal location of an average man was 24 millimeters in Western population, while that of women was 22 millimeters. Compare it with the Indian data. The average aortic diameter, infrarenal aortic diameter in Indian men was 19. I still remember Shivaram sir calling Indians fat, small Indians. The only Indians, the fat seems to be big, rest everything seems to be small. So going by the Western data, according to the Western data, a 2.4 is the average size. So any aneurysm which is more than 2.5 times the normal diameter is at a higher risk of rupture. That is 2.4. 2.5 times is 5.5 is defined as higher risk of rupture. When it comes to Indian men, 19 millimeter is the average diameter of diameter. The same diameter for Indian men happens to be 4.75 centimeters. Now, how are these aneurysms treated? We can treat them by open surgery, where we can bypass or exclude these aneurysms by artificial processes like a dacron or a polytetrafluoroethylene made bifurcated grafts, which are commonly called as pajama grafts because they look like pajamas. Suppose the artery up is close to branches, vital branches, like a renal artery in this case. We can reimplant the renal artery, like in this case. That is the left renal vein. These are the two renal arteries reimplanted, and this is the sac, laid open sac of the aneurysm. This procedure is called aneurysmorrhaphy. Sometimes only if one renal artery is lower, the other renal artery is higher, a single debranching can be done for that renal artery. This is a saccular aneurysm, not just a saccular aneurysm, it is also a mycotic aneurysm. Here, we have used a rifampicin impregnated dacron graft. A repair has been done. The posterior vertebrae is completely scalloped due to erosion, and even the IVC was eroded. So what we did subsequently is, after the repair, we used a vascularized pedicle of omentum and wrapped the repaired graft to prevent subsequent complications like a aortoduodenal fistula or aortoenteric fistula. That is the post-op CT. Now, like open surgery, some patients may not be fit for open surgeries. In those individuals, endovascular repair is also performed. Here, a specialized, as we previously mentioned, a specialized device called an endograft or a covered stent or a stent graft is used. This is a bare metal meshwork on top of which there is a graft layer, which is implanted to recreate the bifurcation as in this case. Here, the blood flows into this graft and exits through the iliac arteries, just like a bypass graft. This is called endovascular aortic aneurysm repair or EVAR. A similar procedure can also be done for thoracic aorta, where it is called TEVAR or thoracic endovascular aortic aneurysm repair. Now, this is a case of abdominal aortic aneurysm, where one of the renal artery is pretty low. So the artery is marked. This is initial angiogram, where we can see the turbulent flow inside the sac. There might be turbulence, but the flow velocity is less. Once the renal artery position is marked, the endograft is placed right at the renal artery and subsequently deployed. Now we can see there is no aneurysm seen. So there is no filling of the sac and no risk of rupture. Similarly, a thoracic procedure can also be done. However, if the aneurysm is close to branches or involving the branches and the patient is moderately fit for surgical intervention, a debranching of these branches can be priorly performed using grafts from a normal artery, and subsequently a simple endograft can be placed so that these normal arteries get supply from the newly debranched grafts. But what about high-risk patients? If they are not even fit for a debranching procedure, or patients who are not fit for prolonged anesthesia, in such individuals, a newer technique called fenestrated endovascular aortic aneurysm repair, also known as physician-modified stent graft repair, is done. Now, what is this procedure? I'll give you an example of this patient. One of the earlier cases we did. Please look at his lungs. Extensive interstitial lung disease, not fit for general anesthesia. He had a juxtarenal aortic aneurysm. I'll just scroll it up to save time. Right after the renal artery, there was an aneurysm. There was the 10 millimeter normal artery below the renal artery was not there. So we had to place the stent above the renal artery while preserving the renal flow. How do we do that? Based on the CT, we make our calculations. We decide where the renal arteries and superior mesenteric artery in this case is coming from, and we deploy the covered stent and create holes for these arteries. These are called fenestrations. That is for the superior mesenteric artery, a scallop, and for the both renal arteries. Here marked by these two red and green circle and yellow half moon circle for the superior mesenteric artery. Now, once we do that, we take the device inside the patient's body in a cath lab. We note the 3 fenestrations can be seen. We do an angiogram, see where the renal arteries are, and we start deploying the graft. Once we partially deploy the graft, we enter through these holes into the renal arteries, the right and the left renal arteries, and through these holes, another smaller covered stents are inserted this way to the right as well as the left renal arteries. This is the completion angiogram, where we can see the blood flowing through both the renal arteries and the superior mesenteric artery. Absolutely no filling of the sac is seen. The blood is flowing inside the stent graft and there is no sac filling. Thereby, the renal artery perfusion is also maintained as well as the aneurysm is also excluded. We follow up these patients closely. By follow-up CT scan, we can see both the key renal arteries, superior mesenteric arteries patent, and the aneurysm is not seen, entirely replaced by the newly implanted physician-modified stent graft. So the aortic aneurysms are elephants in the room. It is definitely there. It's a prevalent problem, while it is also a neglected problem. Early detection leads to better outcomes and longer survival rates. Much more better techniques are evolving at rapid paces. We have customized devices which are also coming in the recent future. Screening at-risk population is the only way to detect aortic aneurysms early. For example, in the UK, every man who's 65-year-old receives a card on his 65th birthday, a greeting card from the NHS wishing him on his 65th birthday, also inviting him for an aortic aneurysm screening program. Such programs do not exist in our country. It is often a teamwork. We often collaborate with the cardiac surgeons, cardiologists, anesthetists to perform these aortic aneurysm repairs. Thank you all.
Thank you, sir. That was a very
Thank
wonderful
you.
talk. Can we take some questions which are there in the chat box, sir?
Yes, definitely.
The first question is regarding what you were telling about, sir, about the screening program which we don't have in India. First question is coming from Dr. Naaz. She has asked that can we have a structured screening program in collaboration with physicians where we can catch an ischemic limb at an early stage?
Mamata will be answering that. Hello.
Hello.
Ma'am?
Sorry, it was muted.
The question was, can we have a screening program in collaboration with the physicians to catch limb ischemias at an early stage?
Oh, definitely. I think so. But it becomes a challenging procedure actually. Maybe it can be organized as a camp part where we can select our monthly as a basis of routine visits where we can go screen the patients. But I think so that is going to be a challenging part because presentation, any patient comes to us with leg pain, leg cramp. So it is a vast thing. Specifically to tell as a claudication, it becomes a challenging part. So maybe more than that, I would suggest it would be to highlight more at the centers, clinical level, where the physicians are well trained, where the surgical capture of these vascular patients would be a better option. That's what I feel. Screening at a public level might not be possible, but definitely clinic levels where it can be organized or can be taken should be a better option, I feel.
If
Yeah.
I can add, sorry, sir.
Yes,
Yeah, just want to add just 2 lines. Madam,
Yes.
that is something, the happened in the breast, cancers, what it was
Yes.
some few, maybe 2 decades back. Now,
True, sir.
actually, many people are coming for the screening, plus because ultrasound and mammo are available most of the places. But I just want to add at this juncture that, this, as you showed those diabetic ulcers, gangrene,
Yes,
which
sir.
I think every general surgeon and everyone handles this. So whatever experience says, in fact, they spend more money than at early stage of a cancer treatment today.
Definitely.
In fact, they spend actually not thousands. Actually, it goes for lakhs.
Lakhs.
That's all. Thank you, man. Yes.
So I was about to say, sir, that we have a screening program in our hospital, but as we know, it's a corporate hospital. The cohort may not be so big. But what we do here is any patient with cardiovascular risk factor, a patient with a past history of smoking above 60 years, with one or more cardiovascular risk factors like diabetes, atherosclerosis, family history of any cardiovascular risk factors like a heart attack, strokes, or gangrene, are screened for peripheral arterial disease with an ABI. Now, ABI may not be there everywhere, but peripheral arterial pulse examination is a part of basic medical examination even for an MBBS student. So, any patient with cardiovascular risk factors should have a mandatory documentation of peripheral pulsations. So, that will create a lot of difference in these. Now, when it comes to claudication, unfortunately, what we have seen is patients with diabetes, especially those with profound diabetic neuropathy, often never complain of claudication pain. their claudication pain, they do not even understand that they have such severe peripheral arterial diseases. So not based on symptoms, but based on risk factors. So any patient with who's prone to develop cardiovascular disease should be screened for peripheral vascular diseases.
The International Diabetes Federation also suggests that annual screening of patients who are just above 40 and have other cardiovascular risk factors. So it's in the guidelines. Especially, we can't screen the public, general public, but people who, like you said, Krishna, the people who
Yes,
have got
sir.
cardiovascular diseases and the patients with diabetes. These are the high risk group populations which should be screened annually once they are above 40 or 50. Then that should be the guidelines.
Yes, sir.
Thank you, sir. The next question is by Dr. Rajgopal Shenoy, sir, requesting for some highlights about the actual role of aspirin, statins, pentoxifylline, clopidogrel, and prostaglandins, and their patency rate at the end of 5 years.
This is particularly I asked because you know that it is commonly used drugs. So everyone, as you told, no, first thing we tell anywhere you go for the vascular is lifestyle modification. First thing, whatever that obesity, smoking, all that thing will come. Second is the pharmacotherapy. This is the area where whether it's a physician or a surgeon or everyone, lots of drugs are being used here. So I just wanted you to, because especially postgraduates also are very important beneficiaries of this. So please take this question, Dr. Mamata and Dr. Krishna, please.
Yes, sir. Let me highlight a bit on antiplatelets, especially the ecosprin. Ecosprin is a medicine where once there is a atherosclerosis and stenotic lesion noted, definitely the patient needs to be on this, whether we are placing the patient without surgery, definitely he needs on ecosprin, so that whenever there is a plaque rupture or first thing is to happen is the thrombotic occlusion. So to prevent that, definitely ecosprin adds up to this. And many studies have shown with statins along with antiplatelets, the cardiac morbidity is definitely reduced. I mean, cardiac related with vascular added complications are definitely reduced when it is added along with the statins. And clopidogrel as such is not a routine medicine, especially in a gastric bleeding patients normally we consider. And most of the patients who undergo with stent, definitely we put these patients on a dual antiplatelets. And pentoxifylline is hardly we use now. It is just a placebo which never used for modification. Again, it is the silestazole which is the routine. Definitely, to some extent, the calf muscle cramps, everything distance, the claudication distance, everything has been noticed. And this has to be followed with the treadmill test, which we routinely do, sir. There is a treadmill test for a claudicant, which we routinely follow up with treadmills and look for the claudication distance with lifestyle modification along with these medicines. And along with that, maybe to some extent, the PVR, what I was mentioning, the wave graphs, the graphical presentation with a good waveform improvement, some improvement in the ABI definitely will give some highlight as the progress or further improvement in the patient's condition. So that's what I feel. Anything to Krishna, you can.
Mike, one of the thing I asked specifically because
yes,
everything has been done to every patient, say some patient, and they are just 60, 65.
Yes.
They would have smoked. Now they have stopped. They have tried also endovascular. They also some atherosclerotic component, diabetic, sclerotic, retrograde, retrograde from the below. Also the interventions have been taken place. Now still there are a group of patients, they come with some amount of pain. What is your experience on this prostaglandins therapy? PG infusions.
Sir, routinely it is used only, what we use these is only at the dermal level. If at all there is a small ulcer, maybe to some extent the rest pain, which causes the peripheral dilatation of the capillary level, sir. Otherwise, most of the times, I don't think so it is going to help in any claudicant or anything. It is only for a non-revascularization patients, which is very important. A small ulcer with that to superficial I'm talking of, with rest pain. To some extent, these patients do well with that.
Okay, madam. Thank you.
Yes, sir.
Anything you want to add, Dr. Krishna?
Yes, my second with Mamata ma'ams, the prostaglandin therapy, although theoretically it has been known to create neoangiogenesis over a long period of time. But in patients with extensive tissue loss and critical limb ischemia, the time frame is not suitable. Like Madam said, it causes the immediate effect that it causes is vasodilatation and more of superficial, the cutaneous capillary vasodilatation, which in fact steals the blood flow from the underlying deeper tissues. So certain cases, it is beneficial in certain individuals, like TAO patients, if the tissue loss is not too high, non-reconstructible peripheral vascular diseases like distal vessel disease, where the endovascular or open surgical options are not there. In such patients, where there are not many options left to treat them, in such patients, definitely it can be one of the techniques which can be tried, but not dependable on.
Not a definitive treatment as such.
Yes, 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 ma'am.
The next question is advantages and disadvantages of different types of grafts, which is the best one, also in the view of cost effectiveness.
The vein, the God-given vein is the best graft.
Autogenous vein is supposed to be the
Autologous
best.
vein is the best graft. There is no debate on that, ma'am. But sometimes the size, availability, everything is a problem. So in such cases, there are artificial grafts. So Dacron is there, polytetrafluoro is there. The ideal choice is a surgeon's choice. Whatever surgeon is comfortable can be used. There are studies which are both ways. Some show Dacron is better, some shows PTF. There are advantages and disadvantages. Dacron is better to handle, polytetrafluorine is better for reintervention. So many factors, but it is the surgeon's choice when it comes to artificial. But best graft is vein graft.
And
Because these are
below
the
knee,
questions,
definitely
you
it
know,
is
which
only
are,
the vein.
yeah, which are
Below the
commonly
knee.
asked. You know, these are the very commonly asked questions all the
So
time.
we would
Sorry.
say infrainguinal or suprainguinal. Smaller vessels,
Yeah.
smaller vessels below the groin, below the inguinal ligament, vein is the best. And higher caliber vessels, if you want to replace, vein is difficult, tedious, make it double barrel or do some special techniques. Best way is prosthetic grafts.
And below knee, no grafts. It's only the vein.
Yes. Nothing like it.
And definitely we have got some option when the vein is not sufficient, where we can go for a composite graft, where the proximal end can be used as a Dacron or a PTFE. Then we can think of joining these two along with the vein and form a common conduit and go it below the knee also. That's a composite graft, what we call it as.
Just
Definitely
to
has
add
got
to
some beneficial.
I believe there are postgraduates. There are the vein graft is so superior below knee, especially like ma'am said that below knee is so superior to the other grafts that if lower limb grafts are not available, for example, if a patient has undergone a CABG, both the great saphenous veins are harvested. Short saphenous vein can be used. If the short saphenous vein is also not good caliber harvested, upper limb veins also can be used. They can be harvested, used, and they still have better patency than most other grafts.
Thank you, sir. The next question is from Gopinath sir to Dr. Krishna Chaitanya sir. What is your experience regarding emergency rupture of aortic aneurysm and what is the golden period?
Sir, 50% of the ruptures do not reach the hospital. The rest 50% of the individuals who reach the hospital are usually contained ruptures. So they are all emergencies when they present with contained ruptures. If the patient is fit for surgery, open surgery can be done if the patient is stable. If the patient is not stable, endovascular aortic repair can also be done, which is presently the accepted norm in a ruptured aortic aneurysm repair. But problem with our country is the endovascular grafts, all sizes are not available readily. So we have to usually call a company and ask see if this size of graft is available. So they'll have to mobilize it from their warehouse and fit. Rather than that, open surgery is a better choice in our setting. So what we do when a patient with rupture comes is we have something called as a compliant balloon, a balloon which can expand to various sizes, and it's like a Foley's catheter. So which we immediately we insert through the femoral artery and inflate that balloon above the rupture, so that there is a the blood loss can be minimized. So with this balloon expanded, we can take these patients. This is called REBOA, resuscitative endovascular balloon occlusion of the aorta, one of the emergency techniques where we can do it so that we can buy time to load some blood into the patient, stabilize him, take him to the operation theater and operate on him.
The next question is also to you only, sir.
Yes,
From Dr. Naaz, ma'am. When would you choose EVAR versus open surgery?
Fit patient, always surgical options are more durable, better, ma'am. There are if the open surgery becomes a more morbid procedure, like a thoracoabdominal aortic aneurysm repair, where we'll have to do a thoracotomy, open up the abdomen, debranch all the vessels, and patient is not fit for this procedure, then endovascular options or a hybrid option where we can do a surgical debranching and endovascular aortic aneurysm can be done. As on now, the durability is definitely better in a fit patient with open surgical techniques. But as I say, 10 years back, some people would not even consider an endovascular aortic aneurysm repair as an option for patients. But today, we have the data where endovascular aneurysm repair is almost having a similar outcome like open aortic aneurysm repair with similar patency rates, similar intervention-free survival rates, and with lesser morbidity attached and much faster recovery time compared to open surgeries. There are cost factors attached. So the decision is not very simple, but in a fit patient, for academic sake, a fit patient surgical option is always the initial option, better option.
Thank you, sir. Anything you want to add, madam?
No, I think so. He has covered everything, major of the things.
Yes.
Yeah.
Excellent presentation by both of you. It was really very enlightening, and you cleared so many of our doubts. I think, sir, you want to add something, sir? Sir?
Hello.
Sir, you want to add something, sir?
Madam, just screening and all that thing, one of the statements made was that 100 years means everybody will get aortic aneurysm. There's nothing new in all these statements because for the simple reason, it's a common statement. Because we are general surgeons, we tell this. Everybody will get carcinoma breast. Suppose you live. Carcinoma prostate, one of the commonly stated. Only issue here comes is, especially this vascular related, because of this anticoagulation, whatever be the procedure, there are definite risks of the bleeding, wherever it is. So what happens is, this is all the triggers. It's all related to quality of life after probably the certain age group, what you said, no? This, especially 65 years birthday card of aortic aneurysm, yes. So obviously there's no end for all these things, but obviously awareness is the ultimate answer and to give a quality of life. Yes, cost effectiveness and those things are also there because screening in the Western countries like carcinoma colon is one of the commonly thing, the so-called, they call it as a, that colon screening, that fecal local blood test in colon is very, very commonly done. Like Japanese, how they had that endoscopy for the carcinoma stomach, ultimately to give a better quality of life. So I think that's all from my side, madam. If Dr. Tejaswini Vallabha, madam, you are there? Just seeing her.
Yes, sir, I am there enjoying listening to
very, very
everybody's
nice
discussion.
Madam,
More on learning.
Few comments from your side. Madam was our past chairman.
Nothing specific, sir. It was, in fact, a good revision for me.
Everybody. Okay, madam. Yes.
Thank you, madam, for joining.
Thank you.
Thank you. I really learned a lot today. Literally become lazy to read, so it matters so much now.
And just one more thing, sir, as you
Yes.
mentioned, anticoagulation and all, antiplatelet, when we are talking of ecosprin, many are worried we have to stop before surgery. So if
Yes,
at all
even
you
sir
want to
mentioned
start,
that.
stop it 7 days earlier. But again, it becomes a complication related. I mean, stopping whether does it really matter? With ecosprin, we do go ahead with all arterial cases. So there is no need to stop ecosprin as such.
Yeah,
Definitely, clopidogrel, when anesthesia part or our part is required, definitely there is a need to stop that.
yes, madam. As
Anticoagulation
again,
as such,
yes, sorry.
yes, sir.
Yeah. As general surgeons know,
Yes, sir.
our problem is somebody is on anticoagulants and come for hernia surgery. So obviously, urgency is there. Spinal cannot be given because the spinal hematoma itself can give rise to paraplegia, more dangerous than anything else. So cardiologist angle, they stop it 5 days. From anesthetic, American Society of Anesthesiologists recommend for 7 days.
Hmm.
Aspirin part is actually not just
Yes.
maybe one next day morning means just previous day. That's all. So only this, especially this clopidogrel. Okay, that's all, madam. Yes.
Sure. Thank you, sir.
So just one more question for you. We commonly come across this limb ischemia, acute limb ischemia. So we have to shift the patient to a higher center. So how during that time, what are the steps we have to take? Like, we have to just shift them, or you add heparin and send, and what
Yeah,
do you suggest?
immediately heparin IV bolus dose has to be given. And what we call it as a golden period is 6 hours within the start of the complaint. Once there is a clot, it takes 6 hours within which has to be operated. But unfortunately, so many times it so happens by the time the patient reaches, it will be 8 hours, 10 hours, 12 hours. So what we prefer doing is first we look for the viability of the muscles. We do fasciotomy. We do look for the muscles viability. Even if a single compartment is viable, a single group of muscle is viable, then definitely we go ahead. Along with that, maybe the soda bicarb to reduce these acidosis and all those things can be taken care with good anticoagulation and all. I think so. 6 hours, we have saved patients even up to 12 hours, 14 hours. And acute on chronic definitely has got a better result than the acute thrombus that is originating from the cardiac, where there is no in situ stenotic lesion thrombosis. When there is already in a stenotic patient, there are collaterals developed. Whereas in an acute thrombus, there are no collaterals. So likelihood that the patient land up with an acute, and they are the ones which are required to be operated to the earliest.
Anything, sir? Dr. Krishna
That-
Chaitanya, to add
Yes,
something?
ma'am. Like madam said, bolus dose of heparin, at least 5,000 units IV should be given immediately. And patient requires some intervention as early as possible. Also depends on the stage of ischemia. There are some classes of ischemia for the academic purpose. Class 1, class 2A, class 2B. So whenever a patient is in class 1 or class 2A, where there is no neurological deficits, and in Doppler, if there are any venous signals, patient can still be managed with medical management alone. But if they progress to class 2B, again, intervention is mandatory. Any patient with class 2B ischemia requires immediate intervention. Class 3 is when, as madam said, the limb is not viable. In such patients, when the muscles are already necrosed, all compartment are necrosed, then I think primary amputation is something which needs to be considered rather than reperfusing, which can be more detrimental in view of reperfusion injury.
Yes, sir.
Okay, madam. I think
Yes.
probably.
Thank you. Thank you. Thank you, both the speakers. It was an excellent presentation and very enlightening for all of us.
Dr. Sarvesh Avare,
Yes, yes, sir.
please.
Yeah. Very nicely taken topic, selected and arranged and moderated by Dr. Naaz, Dr. Savitha, and Dr. Preeti. And all have appreciated that one. It's a limb-saving and life-saving things what has been discussed throughout, and it was very nicely presented by our speakers, Dr. Krishna Chaitanya and Dr. Mamata. I thank our President, Dr. Rajgopal Chairman, for arranging the things from past 4 months and continuing and will be continuing for another till January. So thank you, sir. I thank our Chairman-elect, Dr. Naaz. I thank both the speakers, Dr. Krishna Chaitanya and Dr. Mamata, for their wonderful presentation. I thank all the past
Okay, madam. I mean, both
Thank you all.
excellent present. Okay. Yes. Thank you.